Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Timothy Fenske, who is professor of medicine in the Division of Hematology and Oncology at the Medical College of Wisconsin, and we're going to talk about Hodgkin's lymphoma. Welcome, Tim.
Thanks for the opportunity to participate today, Ravi.
So, Tim, we're going to talk to our patients today about Hodgkin's lymphoma, giving them a very broad overview about the subject for someone who's just started their journey with this disease or in the course of the journey, just trying to give them some direction as to how Hodgkin's lymphoma is approached by us oncologists. So, to start out with, what is Hodgkin's lymphoma?
Well, I try to explain this to patients that lymphoma is basically a cancer of the immune system. It likes to live in lymph nodes, but that's just one place where lymphoma can show up. The immune system is much more complicated than that, and there's other areas like bone marrow, spleen, and these cells know how to move around the body. So they can actually show up in organs as well, but the lymph nodes are one of the most common places they like to show up. So I like to make a distinction that many people are familiar with other cancers spreading into lymph nodes, like say colon cancer spreading into lymph nodes, and that being a particularly negative thing when that happens, versus this where the cancer actually starts usually within the lymph nodes.
And so I understand there are broadly two different kinds of lymphoma.
Right. So we've got Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma, and this is really determined by the pathologist, the person looking at the slides from the biopsy that helped to establish the diagnosis. So we really rely heavily on the pathologist to tell us what type of lymphoma we're dealing with.
So how common is Hodgkin's lymphoma?
Um, it's about 10% of all the lymphomas that we see numbers wise in the United States. So as you can see on the slide, about 8,800 new cases per year. And that's compared to non-Hodgkin lymphoma, which is more like about 80,000 cases per year.
So obviously it's much less common than Hodgkin's lymphoma. And I understand that this can affect a wide demographic in terms of age.
That's correct. I think many people are used to thinking of Hodgkin's being a disease of young people, teenagers and people maybe in their 20s. And it's true. We do see a peak in that sort of late teens and 20s and early 30s. But there is also a peak of Hodgkin's in older patients. And that peak is shifting further out to the right as our population ages.
So as far as Hodgkin's lymphoma goes, I know you said the pathologists are the ones that make the diagnosis. What is it that they're looking for without getting into too much detail? Is it very characteristic? Is it an easy thing for pathologists to pick up?
In some cases, I think it's pretty straightforward, but as you can see on the slide here, there's these characteristic cells called the Reed-Sternberg cell. That's the large cell that's in the middle of that image there. One of the things that's kind of interesting or unique about Hodgkin lymphoma is that the actual malignant cell, the cancer cell, can be a relatively rare cell within the biopsy. So a person could have a 6 centimeter mass, and a very small percentage of that mass is actual cancer cells. There's many other cells mixed in that are not technically part of the cancer. They're just kind of bystanders, and that's unusual among other lymphomas or other cancers for that matter. Usually the cancer cell itself is the predominant cell that you see. So this gets to the idea that a good biopsy is really important, because if somebody just has a very, like what we call a needle aspirate, or even a small core needle biopsy, it may not include those malignant cells, and the pathologist may have a hard time rendering the proper diagnosis.
What do patients usually present with? How does one usually seek medical attention?
It can vary. Some patients just notice some lumps in their neck or under their arm and see their doctor, who orders a lymph node biopsy, and within a short period of time, a diagnosis is made. But other patients, it can be a very kind of long, frustrating journey to a diagnosis. And I see patients who have been struggling, who've known something is wrong for a year or more. And that can include a variety of symptoms, such as some of those that are listed here, like fevers, night sweats, really bad itching in some cases, fatigue, unexplained weight loss. And in some of those stories, patients have seen multiple specialists, allergists, dermatologists, ENT, you name it. And it's not until somebody ordered a CT scan, typically, that they finally realized that this might be a lymphoma.
So I know you mentioned this in passing a minute ago about what it takes to make a diagnosis. So you mentioned that you usually need a good chunk of tissue rather than just a small needle. And what about the need for bone marrow biopsies? Is that essential?
That we have, it used to be, like I think if you go back 10 or more years, it was pretty standard. Every new Hodgkin's patient got a bone marrow biopsy, or even both sides, bilateral bone marrow biopsy was common in many groups. But now that the imaging has gotten much better, PET scans in particular, it is often not necessary, certainly not necessary in all cases, to get a bone marrow biopsy.
So I know once you've got the pathologist to render the diagnosis, that there are different kinds of Hodgkin's lymphoma, though it's just 10% of non-Hodgkin, all the lymphomas, it itself can be subdivided. So what is it that is the most common type of Hodgkin's lymphoma that you encounter?
So this first category of classic or classical Hodgkin lymphoma, that's the vast majority. I would agree, probably about 95%. And there are subtypes that are all listed here within that group of classical Hodgkin lymphoma. The most common one probably that we see still is nodular sclerosis. But in practice, it doesn't matter a whole lot which subtype of classical Hodgkin lymphoma. The treatment is really all very similar, the same. This last category, this nodular lymphocyte predominant Hodgkin lymphoma, that's important to tease that out, because we do often treat that one differently.
So once you've made the diagnosis, made the subtype, then I guess the next thing that is usually done is trying to figure out how extensive it is. So what kind of test do you do to find out how widespread the problem is?
Generally, we try to get a PET scan at the beginning. There are a few scenarios where maybe somebody might need urgent treatment, or they might be in the hospital where a PET scan wasn't feasible at baseline. But whenever possible, we do try to get a PET. It's actually a combined PET/CT scan. And it's pretty standard that it would go from the base of skull to the mid thigh. And that gives us, that really allows us to determine the stage of the patient. Some people may have had CT scans as part of their diagnostic workup. MRIs, I would say, a lot less commonly.
Okay. And I understand that you do sometimes need to do some additional tests depending on what kind of drugs you're going to use. So in some patients, you're looking at cardiac function, lung function. Just to put in perspective, what are these for?
Yeah, the cardiac function is usually an echocardiogram, or maybe some places might use something called a MUGA scan. That is one of the drugs that's commonly used in a lot of Hodgkin lymphoma regimens is doxorubicin or adriamycin. That drug has a small risk of causing weakening of the heart. It usually doesn't, but it can. And we check cardiac function just to make sure that a person has normal a normal, healthy heart to begin with. And most, of course, most people do, but every so often we find someone who had a problem that they didn't realize, and that might change our treatment approach. The pulmonary function is mainly if we're considering using the drug bleomycin. Again, for the same logic, bleomycin can affect the lungs. We want to see what their baseline lung function looks like.
So, and how do you stage it? Like any cancer, you've made the diagnosis, you've done your tests, and broadly, how do you stage it?
The staging's pretty easy in lymphoma compared to other types of cancer, and it's outlined here. So if you just have one group of lymph nodes, that's a stage 1. If you have more than one group, but they're all above the diaphragm, then we call that stage 2. If you have lymph nodes above and below the diaphragm, stage 3. And if you have disease that's not just in the lymph nodes, but in other parts of the body, like the bone marrow, liver, lungs, etc., then that would be considered stage 4. I always, just about every patient, we have to spend some time try to demystify stage a little bit. Stage is really important in some types of cancer, but it's only slightly important in lymphoma. And I try to emphasize to people, even the most advanced, highest risk stage 4 patient, we're still treating with curative intent, and we can actually cure the majority of those patients.
So you just said what's here. So the goal of treatment is cure, and that this is, I understand, one of the most curable of cancers.
I would agree with that, yes.
So how do we get about trying to cure it? So I understand that there's a slightly different approach, whether you are caught with limited disease or your disease is more extensive. Both can be cured, but broadly, how do you go about the patients who have more limited involvement?
I like to try to put patients, if we can, into one of 3 categories. So there's limited stage, which is stage 1 and 2. So limited stage favorable or limited stage unfavorable, and that's unfortunately the term that's been used for years. And I again try to tell patients, even though they might have the label unfavorable, it's still actually quite good. They should have called it good and very good, but for whatever reason they call it favorable and unfavorable. Because even the limited stage unfavorable, we're probably curing 85+% of the patients, but it's not quite as good as the limited stage favorable. So that has to do with how many groups of lymph nodes there are, some of the blood tests like the sedimentation rate, and if whether they have what's called bulky disease. I didn't mention that. You had it on the last slide, but if you have a large lymph node mass, then they'll call that bulky. So some studies have used 7.5 centimeters, some have used 10 centimeters as the cutoff. So I try to put them into this category of, if they're limited stage, is it favorable versus unfavorable? And historically, it's been a combination of chemotherapy, a regimen that you have listed there, ABVD, followed by radiation therapy, although there has been a movement in recent years to try to just use chemotherapy in an increasing proportion of patients.
And I guess 3-4 is probably a little more common. And how do you go understand that there are some different options? And without going into too much detail, how do you decide which chemotherapy approach to take?
So for many years, it was ABVD, typically without radiation, and a full course, which would be 6 cycles. It's very confusing to patients. 6 cycles is 12 treatments because you get two treatments as 1 cycle. I don't know who came up with that, but that's what we've had for many years, and it's a source of endless confusion to patients. But 6 cycles of ABVD was the standard for many years. There was a big study a few years back where they added this drug, brentuximab, substituted that in for bleomycin. So we call that brentuximab AVD. That actually was compared head-to-head to ABVD, turned out to be a more active regimen, and actually more patients alive now several years down the line. So we try to use that regimen, I would say more so for the stage 3 and 4 patients. This BIACOP regimen has been used more in other parts of the world, like Germany, not used too much in the US, I would say.
So, what are just broadly some of the side effects that patients could potentially experience with these regimens?
Um, so most patients will experience some hair loss, although not everyone. The way that's from the adriamycin. The way it's dosed in these regimens, at least ABVD and brentuximab AVD, it's every 2 weeks. Some patients actually would just have thinning of the hair, and some actually will have not that much hair loss, but the majority experience at least some degree of hair loss. If bleomycin's in the regimen, that's the one that we're watching for lung toxicity. So if you are getting a bleomycin containing regimen and you develop a cough or new shortness of breath, it's very extremely important that you let your team know about that, because that drug often needs to get removed from the regimen. Vinblastine and brentuximab both can cause neuropathy, which is essentially numbness and tingling, or other nerve type toxicities. So we will ask people about that every time, and we do sometimes have to change the doses of those. The whole regimen together can cause fatigue, can cause a drop in blood counts, and a risk for infection. So I would say those are the main things. There's also an infertility concern, although it's usually temporary. So that's something else that may be an important issue for patients. It's not always temporary. You can't be sure it's going to be temporary, though. So if it's of utmost importance for someone to preserve fertility, then we need to do something on the front end to address that.
And so, once you've done with your treatment, how do you follow these patients? Like, what is your schedule of follow-ups?
So we usually get a scan partway through just to ensure that they're responding, and then typically a PET scan at the end of therapy, maybe a month or so after all their treatment's done. If that scan is negative, then we conclude that they're in complete remission. And I explain to patients that remission means we can't see the lymphoma. It might mean that it's gone. We need more time under our belt before we can say with more confidence that it's gone. But in reality, with Hodgkin's, classical Hodgkin lymphoma, if you get to a negative PET at the end of treatment, your chance of doing well is quite good. It's probably at least 90%. And so we don't do a lot of scans to monitor. I mean, my practice is to actually, I don't do any unless there's a reason to do one. In the past, there used to be a lot more routine scanning done, but that's been pretty well demonstrated in multiple studies to not actually be of benefit. So there's been a movement away from that.
And as you said, up to 90% can be cured in certain situations, but unfortunately, a few still either don't respond or what do you call relapse. So what are the definitions? Refractory and remission and relapse. These are things that patients often get confused about.
That they did not get into remission, or they didn't have a very good response to their initial chemotherapy. If there's a typo on there, DLBCL, I think we meant HL.
Oh, sorry, it should be HL. Sorry, that is a typo.
Yeah, I didn't catch that either until now.
Right.
If somebody gets into a full remission and then the disease shows up again, we call that a recurrence or a relapse. Those terms are pretty interchangeable. But we would, as you say, as you list here, even on a relapse or even on someone who does not get into remission with first-line therapy, we still get a good second or even third try at curing those patients.
And so when you do have relapsed or refractory disease, how do you approach the patients?
So the approach for many years has been to try to get them into a second remission, or at least as close as you can into a second remission, using a different regimen. We don't usually do the same regimen all over again. We can't, in part because there's a lifetime limit as to how much of that A drug, the adriamycin, you can give without taking on too much risk for heart toxicity. So we typically switch to a different regimen entirely, and you've listed three of the more commonly used regimens here. And there's been a couple of recent studies showing that if you combine one of the checkpoint inhibitors, either pembrolizumab or nivolumab, with regimens like ICE, or there's another gemcitabine-containing regimen called GVD that we combine with pembrolizumab now fairly commonly. Those types of approaches, so either Pembro GVD or Nivo ICE, a lot of places are using those as second line because they have a very high chance of getting the person back into a PET negative state pre-transplant. Then we go on and do something called an autologous stem cell transplant, which I think you have on the next slide, right?
So, obviously, what's the difference between autologous and allogeneic, and how do you choose between the two?
So autologous means that it's the patient's own stem cells that we're using. Allogeneic means that the cells are coming from a donor who could be a sibling or a child or a parent or maybe another relative in less common scenarios. And that really depends on the disease that you're trying to treat and other factors that may be unique to that patient's case. So for lymphomas, for example, probably 90% of the transplants that we do use the patient's own cells. And that's just in large part based on history and just knowing that works for most patients. It has lower risk than a transplant using cells from a donor. So for lymphoma, it's usually the auto transplant unless there's some extenuating circumstances.
So, I know you talked about radiation therapy in the context of the limited stage disease. What other roles, if any, are there for radiation therapy in Hodgkin's lymphoma?
Of treatment for lymphoma, even you had a movement away from using it in the first line setting somewhat, and in part that's due to late toxicities that were seen in patients treated, decades ago with much less sophisticated radiation techniques. But I think that radiation gets kind of a bad rap in that everybody wants to avoid it at all costs, and it's great if you can avoid it, but I'm sure I have patients that I'm certain were saved by radiation therapy. So in the right setting, it can be very important. It kills cancer cells in a completely different way than our other treatments, and it may be the patient's best chance. So if they've relapsed in a localized fashion, or they have one particular problem area, if they have a very sensitive area, like it's pushing on the spinal cord, and you need to turn that around in a hurry. These are all scenarios where radiation can be very important.
So I think that one of the things that you brought out is this is a curable malignancy. So if it relapses, how many of those 10 to whatever 20% who do relapse or refractory, how is their prognosis?
That depends a little bit. So if it's somebody who we think we can get to a stem cell transplant, and let's say with the second line chemo, we get them back into a negative PET state and then go on to the transplant, we have studies now that show probably about 70% of those patients are cured in the second line. There also may be a role for maintenance therapy after transplant in some of these patients. That seems to help increase the rate of patients staying in remission after transplant, depending, on the patient. But and even in third line, I think we are curing some patients as well. So our best shot is the first shot, but we still have a pretty good second and even third try. And then there's other treatments that can be done even beyond that. So it's an evolving field, and there's a lot of tools at our disposal. So I would just add in there though that I have had patients tell me, because these numbers are so good, that everyone tells them, oh, you have the good cancer, you have the one that everybody gets fixed. And well, there's, as we've talked about, there's 10, 20, maybe a little higher percentage if they had advanced stage disease that don't get fixed on the first round of therapy. And patients sometimes really struggle with that. Like, why am I the 20%? You know, everyone told me I was supposed to be fine and I'm not fine. And that can be psychologically a challenge for patients to, I think, to process that sometimes.
But again, as you said, there's hope for them. And this is one of the cancers where a lot of the research is more now towards making things less toxic than making them more effective sometimes.
That's true. And like the example of trying to at least eliminate radiation therapy in some patients is certainly an effort to do that, to preserve high cure rates, but avoid some of the later toxicities that can come up.
Well, Tim, I really appreciate you taking the time to educate us about the Hodgkin's lymphoma. And I hope that we can have you back for another of these educational sessions in the future.
I'd be happy to.
Thank you.
Thanks.